Next, I invite Dr. Rajashree Nambiar, a case of with mysterious bulge.
I shall be presenting a case with a mysterious bulge. This is the story of a 28-year-old lady. She was 6 months postpartum, a lactating mother who presented with pain and redness in both eyes since 1 month. She had defective vision in both eyes since 2 weeks. She had consulted a local hospital and was started on topical and oral steroids, which was weaned off very early as the patient was lactating, and she had worsening of symptoms on tapering of steroids. Her visual acuity in the right eye was 618, left eye was 624. She had 1+ cells. This is the fundus picture of the right eye. There was presence of vitritis with presence of disc edema, presence of submacular fluid, and also inferotemporally and temporally what you see are there was a slight elevation in the retina along with some choroiditis patches. Now if you see the left eye, there was also presence of vitritis with disc edema and submacular detachment, and there was a large choroidal mass which was seen inferotemporally, which was around 5 to 6 diameters in size. Now this is the OCT of the right eye, whereas you have this fluid at the macula, and this is the area where there is a choroidal elevation which is seen temporally. This is the OCT of the left eye, which is showing presence of submacular fluid with and in inferotemporally, if you see, there is a huge choroidal mass with presence of septae and intraretinal fluid. The B scan of the right eye showing a retinal detachment. Left eye we see a choroidal mass. Now this is the FFA, which shows in the early phase hyperfluorescence and hyperfluorescent disc, and similar picture in the late phases. The disc is leaking, and there is no pinpoint leak and pooling of the dye seen in the right eye. If you see the left eye, again you have a hot disc, and inferotemporally there is definitely pooling of the pinpoint leaks with pouring of the dye inferotemporally. So we decided to investigate the patient. Her basic VDRL etc. was negative, MAN2 was negative, IGRA was negative. These were done in view of the choroidal mass. ACE etc. was normal. ICG was not available at that moment, so it was not done. MRI brain and orbit showed a 7.2 into 2.5 millimeter thickening of the posterior wall, which was seen. But however, they advised a contrast and the patient wasn't willing for the same. With a diagnosis of bilateral VKH, we started the patient on a high dose of intravenous methylprednisolone 1 gram. This is a picture of the patient OCT after 3 days. We can see the submacular fluid, and also the choroidal elevation looks the same. Now this patient was discharged with oral steroids, and then she was started on Azoran after consulting a rheumatologist. Now this is the picture of the patient 1 month post-treatment. If you see, the disc edema has resolved, and also the fluid at the macula has resolved. The choroidal elevation is also resolved. There are pigmentary patches which are seen in the periphery. The left eye was, the disc edema again has resolved and no fluid again at the macula. Now the area where there was a choroidal elevation, we have an area of pigment deposit. A melanocytic proliferation is seen temporally, and also pigment patches are seen in the peripheral retina. If you see the OCT, if you see the macula is dry, and also in the left eye, if you see the submacular fluid has resolved, and the area of the choroidal mass has also flattened. So this is the picture of the patient 3 months on treatment. Again, this typical area, this pigmented patch at the area where there was a huge choroidal mass was stunning. So these are my questions to the panelist. In a case of VKH, where you get such a huge choroidal mass, should we look out for other etiologies like maybe a tuberculosis or a sarcoid or a secondary? And the second question is, in a postpartum lady or in pregnancy, does the management of VKH change?
I think very interesting case, Rajashree. I must congratulate you managing it so well. My differential diagnosis in your case will be posterior scleritis. Okay. Because sometimes that kind of giant nodules kind of appearance can be seen there also. And it's a rare, I agree, that bilateral posterior scleritis is rare, but it is not uncommon. Because we had a series with Woodfield Eye Hospital where we analyzed 18 cases of posterior scleritis. So it can happen also, and definitely it causes a lot of dilemma in differentiating between a VKH and all. One thing is that CNS signs are typically absent in posterior scleritis, and posterior scleritis patient typically gives history of pain. Now pain both VKH patient also can have, but VKH patient will have a little more vitritis, will have anterior segment granulomatous kind of inflammation like AC cells and all. How was this inflammation in that patient?
No, she was on topical steroids when she came to us. She had 1+ cells.
Okay, okay. So sometimes it happens that the treatment, if the previous treatment will mask the
Yeah.
features, and pain also may be subsided because of that also. But I will try to take that history and ask typical few questions like whether the pain increases at night, anytime it happens, so that that because of the pain you got up from the sleep. So these are the very history. Sometimes patient actually can help you. And another history is that when you move your eyeball, is there any increase in your pain and all. So this kind of history can help. Ultrasound, yeah, it is there, but I think sometimes if you do the dynamic ultrasound, no, because it's a very difficult condition, bilateral posterior scleritis versus VKH to diagnosis. So only one possible way is if you go to that and increase the gain of the ultrasound. No? So sometimes you will see that the sclera is abnormally hyperreflective, which won't be seen in your VKH patient. But FFA is of no use because can give the same kind of photograph, same kind of clinical picture, pinhead early weak and the placoid pulling there. Is that the thing? And second question was on
In pregnancy and lactating mothers, does the management change anywhere?
Honestly speaking, I have treated only 3 patients only of VKH with pregnancy. So both the patients I have actually, they were 2 of them were already known case of VKH. So the moment they started up the inflammation, I just started the patient on administered Ozurdex. But if you see the literature and talk to your rheumatology friends also, the azathioprine is considered as safe in pregnancy. Yes. But I think only one not treated by me, one of the senior consultant in our Dr. SKG, I think. So her patient actually, the patient was continued on azathioprine and she delivered. So there was no abnormality in the fetus. So azathioprine is considered by the rheumatologist as a safe in pregnancy. But because it is an anti-metabolite immunosuppressive, honestly, I am also very scared. So I'll be afraid to tell the patient that you take azathioprine and continue the pregnancy. I'll leave it to the obstetrician and rheumatologist.
We had a patient on Azoran, VKH patient on Azoran became pregnant, and rheumatologist told to continue Azoran, and she safely delivered. And in this patient, if it was posterior scleritis, that T sign might have gone because of the previous systemic treatment also. But honestly, in that fundus picture, post steroid fundus picture, some sort of depigmentation is there, like sunset, going for a sunset glow.
Even that melanocytic proliferation which you see at the area where there was an elevation.
Very good observation, because if you chronic, I forgot to mention that the only whatever I have discussed, only point against was little bit, but the depigmentation was not that much you see in a convalescent case of VK.
But what about that localized pigmentation where there was a mass? Is it because of
just the RP hyperperturbation has occurred because of when it was resolving? That is my.
It was a huge choroidal mass, so that's why we thought whether it was a TB or a sarcoid, because I don't know whether VKH.
Sometimes the giants they call giant posterior scleritis can have this kind of
huge proliferation. Okay.
But yes, Risha is correct, but it can happen.
Anyway, we will keep the patient under close monitoring.
Thank you, sir.
Thank you.